Welcome back, everyone. We're very fortunate to have this incredible panel of NET experts join us today for a live question and answer session. All of our speakers are deeply committed to the NET community and are active in professional NET organizations, NET research, and of course, they see and treat NET patients as well. It's an honor to introduce today's participants in order of their appearance today. We have Dr. Aman Chauhan, medical oncologist from the University of Miami, Dr. Alexandra Ganji, surgical oncologist from Cedars-Sinai Medical Center, Dr. Nadine Malik, radiologist and nuclear medicine physician from Oregon Health and Science University, Dr. Osman Ahmed from University of Chicago, Dr. Karina Mariaparici, radiologist and nuclear medicine physician from Stanford, Dr. Pamela Kuntz, GI medical oncologist from Yale Cancer Center and the LACNETS president. And we have Josh Mailman, president of NorCal Carcinet and patient advocate extraordinaire. Josh will also be serving as co-moderator for today's question and answer session. And again, this is just a reminder that our programs are intended for educational purposes only and do not substitute for medical advice. Talk to your medical team if you have any questions or concern about your individual case or treatment. And we all have our own opinions. These are our own opinions and do not represent that of LACNETS. The speakers will address general questions. They cannot answer case-specific questions about your individual situation. So with that, we'll start with the first question, and I will give it to Dr. Pamela Kuntz. How is the initial diagnosis of NET made prior to staging and grading?
Thank you for the question, and really a pleasure to be here today. So greetings to the audience. So this is a great question and really one that has to be tailored to every patient. So I think what this is getting at is that what are the presenting symptoms? And this can really vary. Depending on the primary site, if it is, for example, in the pancreas, and that pancreatic mass is blocking a bile duct or blocking part of the intestine, it may cause specific symptoms or laboratory elevations or cause pain, and that may be what initially brings the patient to medical attention. What this question may also be getting at is some of the first tests that are done are often imaging. So whether it's an initial CT scan, if the patient presents to an emergency room, occasionally NETs are diagnosed incidentally. Patients may go seek medical care for something completely unrelated and be found to have a mass on imaging. And then that's what triggers the other things that are in this question, which is around staging and grading, which is done after the biopsy. So maybe I'll stop there.
Thank you. Dr. Ganji, there's a question about watching and waiting, and I know we talked about this a little bit in our session. Is the current trend of watching and waiting for small PNETs driven by the comorbidity of surgery or by the high chance of multiple PNETs not yet visible on gallium-68 dotatate scan?
So first, we'll define small PNETs. The standard guidelines classify small PNETs as anything under 2 centimeters, but there is some variation in terms of whether we believe that it should be under 1.5 or under 2. In terms of why we watch and wait, and these are for patients who don't have hormone producing or functional neuroendocrine tumors, meaning some of these pancreatic neuroendocrine tumors do secrete specific types of hormones, which can give you a variety of symptoms, like you can overproduce glucagon or insulin or things of that variety. And those subsets of patients, we recommend resection regardless of the size. So in patients who don't have specific hormone-related symptoms that have tumors that are smaller than 2 or 1.5 centimeters, we choose to watch them because we have fairly sufficient data in watching subsets of patients that these don't tend to grow very quickly and they don't tend to metastasize if we're able to continue to observe them. The morbidity of the surgery is more related to where they're located within the pancreas. So if they're in the head of the pancreas, which is along the side where the pancreas is stuck to the stomach and the duodenum and the bile duct, sometimes to remove those, it requires a bigger operation whereby you're having to also concomitantly remove part of the stomach, part of the duodenum, and the bile duct, and essentially reconstruct everything. So you can imagine that that's a slightly bigger operation, whereas when they're located in the tail of the pancreas, that doesn't necessarily involve that. And depending on their size and the proximity to the pancreatic duct, we also sometimes have the option of just enucleating or removing the tumor itself without having to take out a significant proportion of your pancreas or other things. As I said, this is a hard question, so I'm giving you a lot of information. So all of these factors kind of weigh in terms of why we're deciding to watch and wait. We don't typically believe that there's a high chance of you developing multiple PNETs unless you sometimes have genetic predisposition syndromes whereby you can develop additional PNETs because you're predisposed to having those. So it's not really because we think there's more that aren't visible. It's because we think that they're quite indolent and behave well. And with an observational approach, we can tailor treatment to basically identify those patients who we think would ultimately benefit from surgery because the growth rates are concerning or there's something concerning on the imaging, because most people actually can get away with not having to have anything done. So the key is, if you are diagnosed with a small pancreatic neuroendocrine tumor and the doctor tells you they never want to see you again, that's not the right approach. You want to make sure that you actually have a plan for continued follow-up and observation. And then depending on where specifically the tumor is and some additional components of the actual pathology report, Ki-67 index, mitotic rate, et cetera, that the approach will be tailored to you.
Thank you.
Hopefully that answers the question.
There was actually a follow-up question or a related question about what's the risk for metastasizing?
So for a small pancreatic neuroendocrine tumor under 1.5 centimeters, from a number of observational studies, we think the risk of metastasis to the regional lymph nodes is anywhere from 2 to about 10%, which is fairly low. And sometimes we can determine if a patient at the time of diagnosis may have metastatic disease identified with basically somatostatin specific imaging and standard imaging like CT or MRI if we see things that are concerning. And again, this is for low-grade, well-differentiated neuroendocrine tumors. When we're looking at grade 3 and neuroendocrine carcinomas, that's a totally different beast, and again, completely different. As they grow, we think the incidence of nodal metastases is higher, upwards of 20 to 30%. And once we kind of hit the greater than 2 centimeter mark, which is why we advocate for surgery in those patients.
Thank you. Well, speaking of higher grade, Dr. Ahmed, is there a difference between ablating the primary or metastasis to slow down the disease progress? And there's a secondary question, is ablation recommended for NEC, the high grade neuroendocrine carcinoma? For example, if the Ki-67 is around 30%.
When we ablate something, really, we don't care too much about the histology per se, or what the tumor sort of looks like under the hood. We really care mainly about the size. So when we ablate something, really our upper limit usually is around 3 centimeters. With that said, we definitely can ablate lesions that are larger than 3 centimeters, but we know that based on our literature and our studies that ablating tumors larger than 3 centimeters, it tends to be a higher rate of recurrence and that sort of thing. So when we treat tumors that are less than 3 centimeters, we know that we're going in to try to get basically a cure of that tumor that we're treating specifically. So that's sort of the answer to that second part. With respect to treating the primary or metastasis to slow down the disease progress, with ablation in general, at least from an IR standpoint, from a percutaneous standpoint, we really don't often treat more than 3 lesions at a time, just because it can become very cumbersome and tedious to do that. Now, with that said, I do know with NET specifically, oftentimes, our surgical colleagues will do the debulking and or intraop ablations. And this is really the only cancer type where we see 18 ablations or 20 ablations. So my role in that situation a lot of times is to sort of be the cleanup person. Sometimes our surgeons can't get some difficult ones, and we'll be asked to maybe get, some that are sort of in the deep regions of the liver that it might just make more sense to stick a needle, with image guidance and ablate.
Thank you. Thank you for that. Dr. Coons, this is a question about sequencing and treatments as well. If there's some small growth observed on a, say, 6-month gallium-68 dotatate PET scan, and there's maybe a small 5 millimeter suspected PNET with no current treatment, when would an SSA be recommended?
So thank you for that question. I might first just kind of clarify that gallium-68 PET scans are really used to complement cross-sectional imaging like MRI and CT, and I can certainly defer to some of my radiology colleagues, but a gallium-68 PET, typically I'll use that at time of diagnosis. I may use it preoperatively, but I do not use that to monitor patients over time. So I don't know kind of this specific situation. And then I might also say an analogy that I'll use for gallium-68 PETs is that we see, I use a light bulb analogy. We see the glow of the light bulb, but we don't see the size of the light bulb very well. And so we might see sort of evidence of a small pancreatic NET on the gallium-68 scan, but I would want to make sure that we had good cross-sectional imaging over time to indicate that there had been growth before we would consider doing any treatment. If it were localized and 5 millimeters, this would go back to Dr. Ganji's comment on we would probably just monitor a very small pancreatic net and likely recommend surveillance and that watch and wait approach.
Thank you. Dr. Ganji, is enucleation or ablation alternative surgical procedures for small nets in the pancreas? I guess the second part is more applicable. Are there other procedures other than pancreatectomy or Whipple? And I think this person was specifically asking about surgical procedures because there were a couple questions about this.
Got it. So enucleation is another surgical procedure, as we talked about, and essentially what it means is if you can kind of imagine the tumor as a marble in the pancreas, we kind of go around and pop out the marble, hopefully with a little bit of surrounding healthy pancreatic tissue. The possibility of doing an enucleation is dependent on the size. I know we're asking about small peanuts, and then more importantly about the location. It's essentially where it's sitting within the pancreas is of critical importance. Other than that, we don't typically ablate these lesions. There are some trials evaluating the role of ablation in small pancreatic tumors. This could include adenocarcinomas or neuroendocrine tumors. But typically, because neuroendocrine tumors are well behaved, and for these small ones, we can frequently favor an observational approach. We don't really rush to ablation because, as with any interventional procedure, there are potential downstream complications. And then there could be, injury to adjacent structures. And in the pancreas, it's one of the things we learn in surgery is, sleep when you can, eat when you can, and don't mess with the pancreas. So when it comes to the pancreas, if you don't have to do anything to it, don't. So if we feel that observation is something that we can do, we wouldn't favor necessarily ablating them if we think it's safe to watch.
Thank you. Dr. Ahmed, what about ablation? There was questions about ablations for pancreatic nets.
Yeah, I think Dr. Ganji answered that very well. I think I would add that, right now there probably is no sort of defined role for ablation. I think the ablations that are mainly being done, if they are primarily what we call intraoperative ablation. So where our surgical colleagues are doing that. I think in our talk, we did mention IRE or irreversible electroporation. There seems to be definitely interest in that, whether it's from a IR approach or a surgical approach to do that for pancreatic cancer. So, we may see that potentially applied, one day for NET, but not right now currently. And then, I think we'll probably talk about histotripsy too, possibly as a potential non-invasive therapy for that as well.
Thank you. Dr. Kuntz, going back to SSA, what are long-term impacts of taking octreotide or lanreotide for 15 years or more? And in particular, I think for non-functional NETs.
So certainly for our patients with functional NETs, those that secrete hormones, we often tell patients that they are on lifelong somatostatin analogs. For patients with non-functional NETs, we'll use SSAs for tumor control, and therefore those may still be for a period of time. And I would say the most common long-term side effects can include gallstone formation. That is exactly why my surgical colleagues like Dr. Ganji may consider removing the gallbladder for an elective surgery that's intended to remove the tumor itself. And we can also have patients or see patients develop high blood sugar. That's something that can develop over time. In addition, somatostatin analogs, the way they work, they're inhibitory. So they slow down lots of processes in the body. And one of the other things that they can slow down is secretion of pancreatic digestive enzymes. So the pancreas has two main jobs, one of which is to secrete insulin and one of which is to secrete digestive enzymes. So patients can develop pancreatic exocrine insufficiency and may require supplemental medications like Creon or pancrease to help with digestion. So if patients are experiencing exocrine insufficiency, they may see symptoms like diarrhea, bloating, gas, and we will consider supplementing that.
Thank you. So Dr. Ganji, I think these type of questions come up about, is it necessary to see a NET specialist at clinic? And this particular person might have small bowel NETs with a small, maybe 3 millimeter NET and is being recommended surgery. So when is it, I guess, important to see a NET surgeon?
Right. So small intestinal NETs, if one has been diagnosed at 3 millimeters, then you've had quite the workup and likely something led you to them doing something like a double balloon endoscopy, or this was found incidentally at the time of a colonoscopy within the terminal ileum. The challenge with these small intestinal nets are frequently the nets themselves within the small intestine are quite small, and about 30 to 40% of the time they can be multifocal depending on where they're located, meaning you can have more than one spot within the small intestine where you have a net tumor that we can't always see necessarily. We can't endoscopically observe these unless you go to essentially a center where they're able to survey your entire small intestine, which is a procedure that not all institutions have. It's something called the double balloon endoscopy, and it requires basically doing an upper endoscopy, going through the stomach into the small intestine, and then something including a colonoscopy, and then they try to go past the large intestine. So usually patients who have incidental small bowel nets that are fairly small identified with no symptoms, it's because they're either having persistent anemia or something that we just can't explain that's leading to an additional workup with these more difficult or complex procedures that aren't necessarily done everywhere. If they're found incidentally at the time of a routine colonoscopy within the terminal ileum, these patients are still frequently referred to surgeons, because what we're concerned about with these small bowel nets is progression of the tumor into the lymph nodes, which can ultimately cause these larger mesenteric masses, which is how we frequently find small bowel nets, not because patients are actually symptomatic from the primary tumor, but from the site of metastatic disease within the mesentery, which can, given the way that neuroendocrine tumors interact with the surrounding tumor microenvironment, can cause some shortening of the mesentery, pain, intermittent bowel obstructions, and things of that variety. So currently, the recommendation for those patients who are resectable is to remove small bowel neuroendocrine tumors. And I think you mentioned what kind of surgery would be required. Frequently, we try to remove the portion of the small intestine that has a net tumor or tumors, depending how much is involved, and then the adjacent mesentery, which is the fat that has all of the blood flow coming in and out of that portion of the intestine, and also where all the lymph nodes are. Depending on the location, that may sometimes include resecting the right side of the colon, because there's a vessel essentially that supplies blood flow to the terminal portion of the ileum and the right side of the colon. And so sometimes you will see ileal neuroendocrine tumors within that portion, and to remove those lymph nodes, you have to take that blood vessel. So if found, you should see a surgeon.
And in particular, when would it be important to see a net surgeon versus, someone in the community?
I think certainly we see patients in second opinion not infrequently. I think the surgery is not particularly complex, and I do think people in the community are able to do a small bowel resection or a right colon resection just as well as a net specialist. It's not that you need a specific skill set. I think the concern sometimes is when you're seeing these people in the community, if a surgeon says, I've only read about this and I've never seen it and I'm not sure what you should do, that's a time to see a net specialist. I think alternatively, if it's a common thing that they treat, because there are plenty of surgeons in the community who are adequately trained in the management of neuroendocrine tumors, and they can do an operation just as well as one of the rest of us, I don't think there's a problem with necessarily having treatment with that person. I don't think you lose anything by asking for an additional opinion. And if you're ever encouraged by any of your medical staff to not get an additional opinion, please do so.
Thank you. Thank you for your very thorough answer. Dr. Ahmed, lung nets, it's a topic that is often neglected. And this question is about specifically if you could discuss ablation for low-grade lung nets.
Sure. So I think the concept of ablation, we talked about it primarily for liver in my talk, but, for the most part, we can ablate a lot of other things as long as, again, sort of using that 3-centimeter golden rule. We do lung ablation. Admittedly, we don't do a lot because, radiation or external radiation is frequently used for a lot of lung cancers. But with that said, if there was a need from the medical oncologist who felt that there would be a role for ablating, it would certainly be feasible to do that.
Yeah, thank you. Dr. Coons, what if the primary tumor can't be located? How does this affect treatment, and where could it be?
So with the development of the gallium-68 PETs or copper-64 PETs, this new imaging modality, I think it's becoming less and less often that we cannot find the primary, although this certainly still does occur. We then call them unknown primaries. Most likely they are hiding somewhere in the small intestine. As Dr. Ganji was commenting, oftentimes we will see very small primary tumors in the small intestine, and that can sometimes occur. Ideally, we would try to identify the primary, and so we do often at time of diagnosis go a bit of a expedition to try to find that, because we can, I think, better tailor treatments to patients. We think now that lung, small intestine, pancreatic nets really have different biology. Our clinical trials are designed to study these treatments differently, and often the FDA approvals are based around specific primaries. Now, that being said, there are actually many common principles for how we manage neuroendocrine tumors. And so, for example, PRRT, it's FDA approved for gastroenteropancreatic nets, which includes small intestine and pancreatic nets. Everolimus is approved for lung, small intestine, pancreas nets, that's Afinitor. So I think there are broadly some common therapies that we can apply across multiple net primary sites.
Yeah, I'm going to direct this also to you, Dr. Ganji, because this may have implications for surgery. What if the primary can't be located, and how does this affect surgery for you?
I think it depends. I mean, Dr. Kuntz, I think, commented on a majority of the salient points, but I think it depends on why they're being referred to the surgeon. Is there a significant burden of disease in the liver that we feel would benefit by surgical cytoreduction, or what specifically? So it's difficult to answer that question without having additional context, but it's not uncommon that we have patients who have a significant burden of disease in the liver that are symptomatic. And in working with our medical oncology and interventional radiology colleagues, if we ultimately decide that this is someone who would be a better candidate for surgical resection, we will do what we need to do to look for the primary tumor within the pancreas or the small intestine. And as I mentioned, they can sometimes be very small. So sometimes manual palpation is the only way you can identify these tumors within the small intestine, meaning we actually have to feel the intestine. And it's not uncommon that we sometimes identify it that way. But we typically don't advocate for a surgical exploration in the setting of not doing a very thorough evaluation of where the primary could come from, because frequently with different imaging studies and with the brilliance of our pathology colleagues, we're typically able to at least identify where we should hone in and look a little further.
Thank you.
Lisa, and I get asked this question quite a bit by patients of, is the primary site the mothership that's sort of spreading cells? And I think, so therefore then the question is, well, should that be removed surgically, or is that why it's important to identify it? And I think that if a patient has metastatic disease, both the primary and the metastatic sites have a risk of potentially leading to spread. And therefore, we really think about treating a patient systemically. And I think that that's really important.
That's a really good point. Thank you for clarifying that. Dr. Ahmed, let's go to you. Can chemo or radioembolization be done after unsuccessful bland embolizations?
Yeah, great question. So, I think just if we remember, really the main limitations of doing any of our therapies, specifically to the liver, is your liver healthy enough? So we always want to make sure the liver function is acceptable. And so we'll check those lab values. And then also just as a patient, are you doing well? Are you healthy? Are you functioning well, sleeping, all that sort of stuff? There's a classification called the ECOG that we assess you. If your ECOG is high, meaning that you're sleeping all the time, then, just related to the cancer, you might not be a good candidate because the therapy might hurt you more than help you. So with that said, it's relatively rare that one of our intraarterial therapies sort of works better than the other, if that makes sense. So it's relatively rare that I do bland embolization for patient and then switch to something else. That doesn't mean we can't do it, but it does mean that usually if one is working, then the other one would work, and they tend to sort of be complementary for the most part. With bland embolization, we are starving the tumors of their blood supply, so sometimes the vascularity or the blood vessels that go to the tumors may be reduced. So we probably would have to wait a little bit if we were going to switch to something else. In general, we don't do much chemoembolization for NETs because there's just more side effects and not really much more proven benefit. And the use of radioembolization is a little more controversial relative to bland embolization.
Thanks. So on the flip side, for someone who responded well to bland embolizations, when would you do it again before trying PRT or an oral treatment?
Yeah, I mean, in our practice, and this will probably vary a little bit by site. In our practice, we tend to use bland embolization for patients who are symptomatic. And because we know if we can get a lot of tumors and kill them, then we can sort of hopefully get some of the symptoms better under control. and or if really the primary site of disease is the liver. All the treatments that we have are great options for patients with neuroendocrine cancer, but we also know it's a journey. And so we want to sort of save each bullet for when it sort of makes the most sense. And for us, when it makes the most sense to do a what we call local regional therapy or direct therapy, is when the primary amount of tumor is concentrated to the liver, because then we can go in and sort of save the PRT for later. And or if the liver is really the only site of this sort of site that's progressing and everything else is under control, that's sort of the other sort of concept.
Thank you. Dr. Coons, this question was upvoted quite a bit, so this is common. When somatostatin stops working, what determines the next course of action?
So I think I'm assuming that we're talking about when we use somatostatin for tumor control. Somatostatin or somatostatin analogs are often used in the first line setting for patients with well-differentiated neuroendocrine tumors. And so what may indicate if they stop working is if we see significant evidence of growth or new lesions. And what's sometimes tricky to determine is what is significant, because we may see 1 millimeter or 2 of growth every few months. And at some point we need to make a decision that really triggers and says we need to change therapy. I really think that that's a conversation between the physician and the patient. I think there are some circumstances where it is very clear if there are significant new lesions or a significant amount of growth. And then deciding what that next treatment is really very patient specific. I talked about that some in my presentation, whether we select a liver-directed treatment, whether we select chemotherapy or PRT is really dependent on the patient, how the patient is doing, where their growth is, et cetera.
Thank you. And on the flip side, are there any studies currently regarding foregoing octreotide injections or somatostatin analogs?
So that's a good question. I would say that at this point, they are still very much considered a mainstay of treatment, both for functional NETs to control hormones and really as an early therapy, specifically for low volume disease and the well-differentiated NETs, as I'd mentioned. I think that where there are some questions and areas of controversy is whether or not they need to be continued with PRRT. That's sort of an area of controversy. I know my own practice is that if a patient is progressing and I'm recommending PRRT, I will stop somatostatin analog. That's if they have a non-functional neuroendocrine tumor. And for functional NETs, there are clinical trials looking at other formulations of somatostatin analogs, including oral agents. So I think that, we shall see, but at present, somatostatin analogs are still a really critical part of our therapy.
Thank you. Dr. Ganji, I think this question came up after maybe something that was said in the conversation with the surgeons about how NETs might spread. And will this cancer always spread even after surgery, SSAs, other treatments, et cetera?
I think a general rule of thumb in medicine and cancer is there's no always and never. So certainly within cancer as a whole, when we're treating it, we typically have a period of observation, whether patients have presented with metastatic disease or early stage of disease, because we just don't know how it's going to behave in different people. And I don't think neuroendocrine tumors are really excluded from this. What we could do is we can say that there's a higher or lower incidence of something spreading, and depending on how you presented. So perhaps you presented with a small bowel neuroendocrine tumor and an isolated liver lesion, and you underwent surgery, and we took both those things out. And if you were to ask, is it always going to come back or never? We don't really know, but based on the data that we have, it seems that it's more likely that it would, given that we had a site of metastatic disease at the time of your presentation. Now, if you presented with an isolated small bowel tumor, we remove that, and you had no lymph nodes, your chance of having a recurrence would be significantly lower, but it's again not an always or never. And then after surgery, whether you would get SSAs or other therapy depends on your stage of presentation and the burden of disease that you have. And ultimately what the goal of surgery was. Was it to remove everything? And are you higher risk for having a recurrence? So sometimes in those patients, we'll start you on somatostatin analogs if you were actually sensitive to receiving it. So we would have wanted to see uptake on some kind of somatostatin type imaging. Otherwise, we won't just give you octreotide or lanreotide. And then other treatments may or may not be available depending on the type of primary tumor. So I think we were asked about the identification of the primary and why it could be important. It's because it can also guide us in terms of what additional therapies may be available to you down the line.
Thank you. Thank you. Dr. Kuntz, we were talking about somatostatin analogs for tumor control. This question talks about it for symptom control. So maybe after switching from lanreotide to octreotide, symptoms are worse. What's the maximum dose of octreotide or lanreotide? And how many months would you give it before switching?
So I will say that sort of this switching back and forth between octreotide and lanreotide is also an area of controversy. I'd say that that's certainly something to consider for patients who are maybe having side effects from one or the other. But I think that if it's a matter of controlling symptoms from hormones like carcinoid syndrome, switching from one to another may not be something that is going to be effective. And so then it's about thinking, would you shorten the interval in which you're getting the somatostatin analog, so going from 4 weeks to 3 weeks? Could you consider increasing the dose? There are also other therapies that include telotrestat, that is specifically for carcinoid syndrome and is for patients with diarrhea predominant carcinoid syndrome, and that was approved on the basis of reducing bowel movements. And then the other question is, well, if patients are also having progression of disease, we may need to actually select a therapy that targets and provides tumor control. So Dr. Osman talked about using chemoembolization or radioembolization or gland embolization or ablation itself to really reduce tumor bulk. Dr. Ganji may use her tools for cytoreductive surgery. So there are lots of other ways. And again, I think really one of the takeaways today is tailoring our approaches to each individual patient that's in front of us.
That's so important. Thank you. Dr. Ahmed, histotripsy, that's been so popular since you brought it up last year. And again, thank you for the update this year. Where is the histotripsy treatment available? And is there a list of centers where it's available?
Yeah, thank you. The short answer is close. The study is still accruing patients. With that said, it's still only being offered under the research protocol, meaning it's not sort of commercially available yet. I believe the company has submitted for FDA approval based on the initial data that we've collected. And so hopefully we will hear about its approval sooner than later. I'm optimistic about that. And as far as current sites that have it, we are one of 10 sites, again, under the research protocol. So this is being done as a research protocol. If you essentially Google histotripsy with clinicaltrials.gov, it will bring up the list of 10 sites, which are primarily concentrated around the Midwest because the study started during COVID. And so they were trying to geographically keep all the sites close to each other. But I hope and I expect that if and when this gets approved as an FDA-approved treatment, some of the bigger centers will adopt this and it'll be a little bit easier probably to get throughout the country.
Thank you. We look forward to that. Dr. Kuntz, grade 3 well-differentiated NET, that is a big topic. Should grade 3 well-differentiated oligometastatic NET in the liver be treated systemically first or with liver-directed therapy? And could you also define oligometastatic?
Sure. So, and maybe I'll add the addition of well-diff grade 3, although I presume it's been discussed many times. But well-differentiated grade 3 NET is a new category in the World Health Organization kind of criteria or categorization of NETs. And because it's new, we still don't know how precisely we need to treat those differently than the grade 1 and 2 well-differentiated NETs, or then poorly differentiated. And so although we are seeing more and more of these, and I would say I typically start with systemic treatment because I think we worry that these tumors may be more aggressive, though ultimately what we end up doing is borrowing from both treatment buckets, both from the kind of well-differentiated grade 1 and 2 bucket that we've typically developed that includes somatostatin analogs, PRRT, targeted therapies, liver-directed therapies, but we may also end up borrowing from the poorly differentiated neuroendocrine carcinoma bucket that includes chemotherapies, including platinum etoposide. We may use capecitabine temozolomide. And that really depends on the biology of the cancer, the patient in front of us, how quickly the cancer is growing, where it's located, what symptoms the patients have. So I think that my rule of thumb is generally to start with systemic treatment, but then we can consider other therapies.
Great. Dr. Ganji, what about you? When would you operate on grade 3 well-differentiated oligometastatic NET?
Typically, we don't favor surgery as the first approach necessarily. Again, this is dependent on the primary site of disease and the location of the oligometastatic disease. I think that's of critical importance. And then another thing we look at is the Ki-67 index. So essentially, within the subset of well-differentiated neuroendocrine tumors, there's quite a wide range of Ki-67 indices that you might see. And we have some data looking at patients retrospectively, whereby surgical options seem to benefit patients who have a Ki-67 less than 55%. It seems to be the cutoff. So one of the things we may look at in determining what the sequence of therapy is including that, and ultimately discussing it with our multidisciplinary tumor board to see what other regimens we may want to entertain. So I think Dr. Kuntz hit the nail on the head when she said it depends on the patient sitting in front of us and what other areas we may need to borrow from, but no absolutes.
Yes.
I forgot to define oligometastatic for you. So oligometastatic really refers to having a limited number of metastatic sites, typically confined to one organ. So in this case, presumably they're discussing kind of oligometastatic disease limited to the liver and generally even a limited number of metastatic sites in the liver.
Yeah, thank you. Dr. Ahmed, any comments in terms of what you would do for liver-directed therapy with this?
Yeah, I mean, I think Dr. Kuntz has really well illustrated this, and I'm sorry I'm joined by another future interventional radiologist here. Yeah, I mean, we definitely sort of make these decisions in a multidisciplinary tumor board format, and we sort of tailor the right treatment for the right patient. And if we felt that liver-directed therapy made sense, then we would proceed with that. And again, sort of using the same principles of liver only or sort of only liver progressing disease.
Thank you for that. And we welcome any future interventionalists or anyone to come into the NET field. Well, thank you for this fantastic session. I'm now going to hand it over to Josh, who will moderate the second part of our Q&A.